Excellent. All right, cool. So I think I've given this talk sort of before, but I've modified it some since the last time I've given it. And it's entitled EEG Variants, the Good, the Bad, and the Ugly. It's kind of a brainchild of Dr. Gowan's benign variance talk, which she also gives, which is excellent. But I kind of pulled a whole bunch of images from an EEG text that's online, and we'll just kind of review a whole bunch of things together and try and make sense of this, This is from The Good, the Bad, and the Ugly. Of course, Clint Eastwood, being the guy that he is, he's constantly staring people down. And I like to envision him, staring down. Maybe I have to go over. There we go. That's probably what it is. There we are. Staring down hipster and be like, oh, this is really ugly. What a disaster. But there's going to be some normal in here too, which will be really, really great. So anyway, also AP technically stands for audience participation, if you like. This will be fun. This will be great. So let's do some back and forth. It'll be great. So I really appreciate you guys. Like I say, our job would be a lot harder if you weren't around because we'd have to run around and hook people up and monitor. That'd be impossible. So thanks. I don't have any disclosures yet. So the first thing is we're mostly talking about epilepsy when it comes to the EEG. The EEG can detect, obviously, risk of recurrence of seizure, can detect seizures, it can detect encephalopathy, and it can also detect focal, structural, or functional lesions, which can be really, really useful. And so probably the most important thing we need to talk about is what is a seizure and kind of understanding, I guess, when you're hooking somebody up, what's your pretest probability that they actually have epilepsy? That's kind of a neat idea. And basically, a seizure is a sign or a symptom associated with abnormal electrical activity in the brain causing your symptoms, which is where we come in and we're like, yes, there was a ton of changes during that event, and there's a rhythmic evolving pattern during that event, and that's probably a seizure. And then we can kind of make conclusions about whether or not the patient needs more seizure meds or which seizure meds or no seizure meds, and maybe they just need therapy. Oh my gosh, what an amazing thing that we have here at the EEG. So anybody know how we diagnose epilepsy? It's okay if I'm not totally sure about this one, but there's a couple ways we can do it. Yes, separated by time or more. So if I meet somebody in clinic and they're like, every month I fall to the ground and I shake and I bite my tongue and I have incontinence. I'm like, whoa, every month? For how long? Like 6 months? They're like, you've had 6 events? Like, absolutely. I'm like, well, you just have epilepsy. I don't even need an EEG for this person. Like, they're going to seize again for sure because every month it happens. Seems pretty fair. You also can have one unprovoked seizure, right? And then that's where we come in, like with the first seizure. It's like, what's the chance they're going to have another one, right? So we're trying to figure that out, and we usually send off MRIs and EEGs to figure this out. So 2 seizures separated by time, 1 seizure with an abnormal interictal or ictal variant on the EEG. That's enough. You also could have 1 seizure you think is a seizure and an intracranial lesion, which explains seizures. Like a brain tumor plus a first seizure is pretty obvious. Like, oh man, this person probably needs to be on medicine. That seems pretty fair. There are some intracranial lesions that are not super epileptogenic, though, like an arachnoid cyst, for instance, is just a fluid-filled space. It's kind of a developmental thing. We see it in people with headaches, too, and it's like the bane of our existence. We're like, your MRI is not normal. But I don't know what to make of it because this thing almost never causes problems. But here's a gigantic fluid-filled space inside your head. What a great conversation we have with those people. You can also think about genetic testing, and 1 nocturnal seizure is kind of a new thing because we think about SUDEP. If you have really frequent nocturnal generalized tonic-clonic seizures, you're more likely to have sudden unexplained death and epilepsy, especially if you're an adult. We really, really worry about that because they might live by themselves and there's nobody else to be like, you got a seizure, man. So they might have had 10, who knows? So anyway, that's basically how we diagnose. Super. Not the most common disease on the planet. Definitely headache is more common than this, but it's still pretty common. It's about 1% of the general population. There's also this unfortunate entity called febrile seizure, which occurs in about 2 to 4% or 3 to 5%, depending on who you read. And they do slightly increase your risk of epilepsy, with 1 epilepsy syndrome often presenting with febrile status, and that'd be Dravet syndrome. So if you have somebody coming in with febrile status and they have ataxia and global developmental delay and all this other stuff, you're like, oh, this could be bad. Versus if you have somebody with a febrile seizure has normal development, normal birth history, no brain surgery, no meningoencephalitis, no head trauma, no risk factors, then chances are they actually probably don't have epilepsy. But sometimes we send EEGs anyway because the family's like, look, it's the 6th time this has happened. We just really need to know. And we're like, all right, we'll test him. What the heck, or her. Super. There's also a pretty high risk of having a seizure in your lifespan, but not everybody who has 1 seizure goes on to have epilepsy because that includes people like alcohol withdrawal and intoxication on other things and stuff like that. So cool. What could be a seizure? Well, it should be a paroxysmal phenomena, generally, unless it's status. If it's status, it could be continuous, I suppose. But you'd think a symptom of a seizure should come and go. And during a seizure, it really should be a positive symptom. Do you guys understand what a positive symptom is? We can talk about that, of course, but something. So the definition of a positive symptom is something you have, but you shouldn't have it. It's like extra movements that don't belong, or like I see things in my vision, not I'm blind, because that'd be a negative symptom to not see things, right? I feel things on half my body. That'd be maybe a hemiparesthesia from like a parietal lobe seizure, or I have this sense of doom that like comes on like just before I fall on the floor and shake and bite my tongue and stuff. So that's a positive symptom, as opposed to a negative symptom, which would be more like stroke. So I can't move half my body. Okay, that sounds more like, and if it's hyperacute in onset, probably stroke, especially if a seizure didn't precede it, because we know Todd's paresis is a real thing too. But like anesthesia, we usually think that's probably not seizure, because that would be like loss of neuronal function, not gain of function, if that kind of makes sense. Visual field cut also, meaning I don't see this chunk of my vision. That would be a negative symptom as opposed to a positive symptom. Altered mental status is tricky. It kind of straddles both. I kind of think of it as both a positive symptom and a negative symptom in that case. But just know that if somebody's describing positive symptoms and then they have a bunch of negative symptoms afterwards, you're like, oh man, this really could be seizure for sure. Absolutely. So, what puts you at risk for seizures? Lots of things. You can have genetic causes, any kind of cerebral insults like stroke, tumor, bleed, inflammation from, say, like an autoimmune encephalitis, anything that damages the outside of your brain called the cortex, that could make you seize for sure. People with hippocampal sclerosis, are highly likely to seize, and also they're highly likely to be medically intractable for sure. Previous surgeries on your brain, obviously, if the neurosurgeons do stuff to your brain, they've damaged your neurons. It's like they're doing their best, but hard to leave all the neurons alone when you're doing brain surgery. And then certain metabolic derangements can make you seize. HIE when you're a baby also causes just a diffuse injury to your brain. So. How do you provoke seizures? Well, you could have a fever or electrolyte abnormalities or stop breathing. That would make so you have a seizure for sure. Like a breath holding spell person, they'll fall to the floor and shake, but it's because their oxygen dropped, not because their brain causes spontaneous seizures. Hypotension too. So if you have like a syncopal convulsion, the classic story is, well, he passed out, but I caught him. You're like, oh, really? That's really good of you to catch that guy. He didn't hit the ground, but then he shakes because you didn't get his head to the ground fast enough, so his brain wasn't perfused, and so he had a seizure. So that's usually not seizure either, because, well, it's hypotension causing that. So infections can cause you to have seizures, obviously autoimmune disease, and then we activate seizures sometimes, so that's pretty fair. Cool. Also realized there was an episode of Pokemon that caused like 500 ER visits at one point in Japan. Just so you know, if patients are ever like, don't need to worry about screens. I mean, you certainly can. You can actually watch this YouTube video later if you want, and it's surprisingly similar to our photic lamps. It's like very close. Yeah. This is alternating, and it's actually alternating red and blue. So these two screens, if you can imagine, at 15 hertz, like red and blue, that was what was in this show for like 10 seconds. And a whole bunch of people had seizures, and Japan was like, we really should take this out of our TV because we don't want this every week. Like, this is bad. So generally, TV shows don't have those frequencies anymore. Obviously, police lights and ambulance lights are just not fast enough for the most part. Like, you really need to have 15, 20, and 30 hertz generally to see photoparoxysmal response for the most part. Some genetic epilepsies will have it at slower, especially Dravet syndrome can have it at slower. Again, I keep bringing that one up. But be aware that most of the time people are asking, like, can I watch TV? The answer is, yeah, you really can. I mean, I guess if you have a seizure every time you're watching TV, we should think about this, because maybe you do have a reflex epilepsy. But most of the time people will seize randomly in front of the TV, and we just happen to spend like 2 hours in front of the TV a day. So that's actually pretty probable. What a hard thing. But we also double check, and appreciate you guys for noticing that photoparoxysmal response and doing the lamps for us to see if we can use, say, Zeiss glasses or something to help people. That's a really good thing, because we just give them blue lenses and all of a sudden, boom, they do better and they don't have as many seizures. So that's great. For instance, of course, I've seen also red block before, which is really unusual. Like, you don't usually think of that, but occasionally it does. So we appreciate you guys testing red, orange, yellow. No, red, yellow, green, blue, right? I think that's right. Orange. See, from one Miller to another, I appreciate you. Red, orange, green, blue. There you go. That's right. Which actually is the best advice you can give somebody with photoparoxysmal epilepsy too. You bring me to a good point. If they ask you, what do I do if there's lights in my area? It's don't close both eyes and walk away, because you'll fall and hurt yourself. Patch one eye and walk away. That's the way to go. Completely agree. Strong work from one Miller to another. All right. So a seizure is an abnormal electrical activity that should start, change, and end. So it's not something that's throughout the whole thing. That'd be more like an interictal ictal spectrum variant or status, right? I guess technically status is always the exception to my paroxysmal rule. But that's kind of what we're looking for. A focal seizure shouldn't start everywhere. It should minimally be hemispheric, and then it should spread to neighboring or more remote brain regions. If say it's going contralaterally, it can either spread in the hemisphere through U fibers or contralaterally via commissural fibers. And this is just how to think through the structure of the brain. Realize that the cortex is the outside part of the brain. The white matter connects the cortex to both the ipsilateral self and the contralateral kind of analogous piece on the opposite side. And then there are fibers that project deep too. So you can imagine that maybe you have a seizure of a deep region that then propagates superficially and boom, the ictal pattern comes out, but the patient knows their symptom before the seizure. That sometimes happens too. And so you won't see the ictal pattern immediately on scalp until it becomes superficial, which is a tricky thing. And just a reminder, the brain is a tangle of wires. So the start of the seizure is really the most important. But once the seizure has gone on for like a whole minute, we actually don't really know where it started. I mean, it's gone all over the place by that point. So this is where you guys also come in with our SPECT tracers. We just want to get them injected as fast as possible because we're trying to prevent catching the spread of it. We want to catch the very onset and realize that seizures can spread through the cortex with these things called U fibers, which kind of basically bounce from one gyrus to the other on the same side. And then commissural fibers connect, say, to the left and right temporal lobes. So temporal lobe seizure people will lose awareness early because it goes through the commissural fibers, knocks out both their temporal lobes, and they're like, I'm gone. Versus frontal lobe people, they'll often have seizures that look really bizarre, especially rostral frontal lobe, because they'll have weird movements and it won't knock out both their Page circuits. So they'll remember a code word for you in that case. So also give code words. Good job. Thanks for that. And then, like I say, projection fibers kind of go superficial and deep. So that explains why some people with deep focal onset seizures have no ictal pattern at the start until it gets big enough or spreads superficially. So I hope that helps anyway for thinking through like what could be a seizure to start. So cool. Also realize that there's some semiologic differences between epileptic seizures and PNES, which is super. Which is another common etiology we see in a third of medically intractable epilepsy is psychogenic non-epileptic spell. So how do you guys feel about like defining the difference between the two? Like what kind of features are present with epileptic seizures, I guess, versus PNES? I don't know. Maybe we'll start with epileptic seizures. Yes, agreed. Very good. And other features might include like, lateral tongue biting. That's a pretty fair thing to ask about. Or incontinence. That's usually present in epileptic seizure and not psychogenic non-epileptic spell. And post-ictal state, very common. Also, the duration is quite a bit shorter. So epileptic seizure, people usually say it's 2 minutes. And PNS people will say it's 5 hours. And you're like, oh my gosh, like, kind of surprised you're not dead right now, but it might be PNS. Who knows? We'll have to see, Also, epileptic seizure folks will have seizures at night and during the day a lot of times versus PNS folks will only have them during the day or only on school days, never on the weekends. So that's kind of interesting. Also, epileptic seizure people have their eyes open and PNS people have their eyes closed. So there's actually a really great paper that I didn't write, but kind of wish I did. Well, what can you do? Here we go. It was written by Hema Patel and David Dunn and others who I should know. But anyway, we'll include this in the talk just in case you're curious about reviewing these things whenever you're thinking, is this PNS or is this epilepsy? And you look through the history and kind of the description of the seizure and maybe help put them in a bucket even before you monitor them if you'd like. It's just kind of fun to guess sometimes. Though we always take medically intractable epilepsy seriously because once you're there, you either have really bad epilepsy or you have PNES, right? And then we really need to figure it out. Versus for the one who's just had one seizure, this isn't so important because we're really just trying to figure out, do we need to have you on meds or not? So it also kind of depends a little bit on the question, but realize that there's a big distinction in the history and the look of these, which can be really helpful. Cool. So back to this. Know that there is a free atlas online. It's right here, actually, which I can include. It's about 80 pages, but it's got a lot of really nice pictures. And basically, I lifted all the pictures from there. So got to give props to them. They did a good job putting this together. This would, of course, be the good. So this would be a normal awake EEG, right? So you have, left temporal, left parasagittal, mid sagittal, right parasagittal, right temporal chain with nice anterior to posterior gradient. You got kind of smaller amplitude, more polymorphic rhythms in the front head region, and then a moderate amplitude posterior dominant rhythm in the back of the head. Hans Berger, of course, didn't know where it was because he only put 2 electrodes on the head, but you guys put way more than that on there. So we know that the PDR is actually posterior, not anterior. That's good. And tends to be alpha in adults and have this developmental period through kids, which we'll talk about. So this would be a normal awake EEG with eyes closed and relaxed. So super. Now that we're also going to talk generally about kind of what's bad first before we talk about the good, because once you know like what an interictal looks like and what a seizure looks like, then it's a little easier to think through, okay, this is probably a benign variant because it doesn't meet the bad sort of criteria. So this was Pierre Glure. He was an epileptologist from Canada who kind of defined things called the Glure criteria. And I love just reading old literature about stuff. I find it really, really interesting. But he talked about they need to be paroxysmal, they need to be high in voltage, they need to be spikes and sharps. They need to have a frequent slow wave after potential. So you kind of describe the look of what is an interictal versus what is not. Rarely emerges from a normal background is another comment that he included, because if you do have focal discharges, you can often notice some focal slowing in that same head region. A lot of times if you look really, really close, which is good to notice in addition, because it kind of makes you feel like, yeah, I'm correct about this being an interictal, because there's also focal slowing in that same head region, which is really, really neat to see. When you do see it, it's like give yourself a pat on the back. And then the abundance and consistency and localization helps us too, because if maybe we see like one discharge on a study, we're not so sure, but if we see like hundreds of them, we're like, oh, absolutely, this is left temporal irritative zone that we can talk about. And then irritative means the chunks of brain that cause interictals, versus the epileptogenic zone is the piece of brain where the seizure starts. We think those two approximate each other, but they're not equal. So it is important to realize like where are somebody's interictals on an EEG, which is important. So anybody know the Glure criteria? It's okay if you don't, but it's basically what we're looking for. So they ought to stand out from the background. So if it looks the same as other chunks of the background, it's probably not interictal because it's probably not big enough. That's kind of the idea. You usually don't have interictals continuously on the tracing. So that means then that if you're going to label one, it should probably be bigger than everything else. That would make a lot of sense. Sharp means it's I have less than 100. I should be less than 200. Wow, this is a huge mistake. Sorry, my bad. A small box is 200 milliseconds, isn't it? Dang, I'm struggle bus. Except I'm also, where's my mouse? I'll find it. There we are. That's perfect. Yeah, it should be less than 200 milliseconds, so less than a small box. I think my fingers were too fat there or something. Then we have the spike, which is less than half of a small box, so less than 70 milliseconds. Unless you're talking about a neonate, then we say less than 100. Why is that? I should know. That's just us not deciding what we even are calling things. Having aftergoing slow wave is especially nice because the spike is the depolarization of the superficial neuron, and the wave is actually a hyperpolarization of a deep neuron. But because it's hyperpolarization of deep, they both go up, which is interesting. So that's actually a two neuron system when you see a spike wave, as opposed to just a spike is single neuron system, which is scary, but less scary. Spike waves, you're like, oh yeah, this person has epilepsy for sure. No question. Credible field of distribution is meant to keep us from calling artifacts. So if you bonk your head funny and you have left occipital and left frontal, but nowhere else activity, you're like, that's not really credible. Like, why would it be in those two places, but nowhere in between? So it doesn't have kind of almost like a mountain with a peak kind of distribution on the head as you'd expect a focal discharge to have with a near field. Asymmetric means the front swing should be a little steeper than the downswing, because the symmetric things would be maybe posts or lambda or something like that, a little more isosceles. And the disruptive background is especially nice because if you have a spike wave, generally whatever's underneath it shouldn't be overriding it because it's so big. So that means no normal rhythm overrides a discharge. So, awesome. Also, not every potential that's sharp should be epileptogenic, right? You have vertex sharp transients. Those are sharp. Everybody's got those, right? It's like, don't call those. Oh man, everybody's got epilepsy then. It's a mistake. And then if you have, let's see, slow waves by themselves also are less diagnostic significance, unless it's like terta or aorta. Those are two, temporal intermittent rhythmic delta and aorta, occipital intermittent rhythmic delta, are technically interictal variants of temporal lobe epilepsy and absence. I don't know why aorta and absence are together, but they are. I have no idea why that is, but it'll be on your test, maybe. Okay. Let's see. And then also, the last bullet point is really probably more for us just to be careful not to overcall things, because once you diagnose epilepsy, it's very hard to undiagnose it. So we'll just be extra careful not to overcall things. And so sometimes I think you guys do a great job of like labeling, and we really appreciate it. So keep doing that. If we don't always call it, it's just because we just don't want to label everybody epilepsy. So we're thinking, maybe this isn't quite enough. We'll tamp this one down. And we read the history, and our pretest probability is pretty low. So, So obviously I have an epileptiform discharge on the left there with a really asymmetric, higher amplitude than everything else on the whole page, and presumably everything else on the whole tracing. If you think about the whole tracing as being an amplitude, this should be higher than everything else. It also has an aftergoing slow wave potentially with it, or if you think of this potential, I guess a slow wave going there. So this one's a little biphasic. Maybe even it has a couple other channels doing this adjacent to it. That's possible to give it a good localization here. This would be a nice sharp, a little less spiky, a little more broad at the base. And then we have just excessive beta, which is non-specific. And then we have maybe a PDR here with a little bit higher amplitude on this one than everything else, but just not enough. It also doesn't interrupt the background rhythm either. So we wouldn't call this interictal as opposed to this, if that kind of makes sense. Super. All right, then for ictal tracings, we should see rhythmicity and evolution. You got to see those two things together. If you don't see them together, you might be looking at a benign variant. That's probably the most important thing to know from this talk, actually. So if you have rhythmicity, which is greater than 2.5 hertz by definition and abutting each other, and there's spike waves or waves with admixed spikes in it, we're almost always going to call that a seizure if it's faster than 2.5 hertz. If it's slower than 2.5 hertz, we start to call that the interictal-ictal spectrum, especially if there's period, meaning flat between the two waveforms. Then we're thinking generalized periodic discharges or lateralized periodic discharges, depending on their distribution. And then it should have evolution, which is change in frequency and morphology, meaning either speeds up or slows down or becomes more complex or changes in some way, as opposed to staying the same morphology throughout. Because if it's the same throughout, that implies there's not as much evolution, and thus maybe it's a benign variant we can think of. That'd be kind of the idea there. So also, if you're watching the video and the patient's like, falling over, shaking and biting their tongue, that helps. Who knows? You can also use that too. You guys already do. I don't know why I'm saying that. Anyway, so this is a nice ictal onset from the left frontal head region. It starts off as like kind of a low amplitude, fast rhythmic activity that's probably in like the gamma or even maybe slow, maybe fast beta range, sorry. And then over time, it builds an amplitude, it slows down, and it spreads to adjacent channels. So it winds up in C3 and FP1. So you can see how that would be a really impressive focal onset seizure from a single channel. So just another plug for the Atlas. It's online. Okay, let's go through the good. So normal wake. This is a 24-year-old female. Got eye blinks, which are positive potentials in the frontal head region because your retina is relatively electro negative compared to your cornea. So that means then when you blink, your eyes roll up, and so the frontal polar electrodes see a big positive. That's why there's always downgoing eye blinks. Unless you're enucleated, then there's no downgoing. You may notice that there's only half of the thing looks like an eye blink. You may have a patient with only one eye potentially. That's possible. Great. Anyway, I've fallen into that trap before. Anyway, and then we have anterior to posterior gradient we talked about, kind of faster frequencies in the frontal head region, and the PDR in the back of the head, which in adults should be alpha. So when Dr. Marquand talks about the alpha rhythm, he means the posterior dominant rhythm in an adult. Though we see peds, so to call it alpha always, I usually don't call it that, but he also means when he says alpha, a well-regulated, well-sustained, meaning it only occurs when you close your eyes, extinguishes upon eye opening, and when you close your eyes, it could sustain the whole page if you leave your eyes closed, and it's the right frequency. That's what he means by when he says that. So, super. Great. Then we have posterior dominant rhythm. The eyes open, boom, it disappears. Thanks for doing eye closure and eye opening for us. It helps us to count that guy and see how it's different than the front part of the head, which is important because if we don't see anterior to posterior gradient, we're worried about like hypsarrhythmia or some horrible, epilepsy. We like to see that at the very beginning of the tracing, which is really helpful. This would be a nice example of excessive beta, meaning basically every second there's faster frequencies atop any normal frequency on this tracing. So, this person, I would say, do they even have alpha in the posterior head region? Maybe this is even a slow alpha variant potentially because they really are only like 6 hertz-ish in the posterior head region, or potentially they're not relaxed with their eyes closed. This could also be like lambda in the posterior head region. But then we have these really fast frequencies seen throughout, and that's usually a medication effect almost always. When we see that, what that means is we'll be less likely to call discharges in this person just because beta on top of a waveform makes it look more spiky. There's just a faster frequency on top of slower frequency, and so everything looks more spiky at the peak when you have this. So we'll be extra careful not to overcall it in this case is kind of what that means. And beta should be faster than 13 hertz activity, less than 30. That would be gamma if you're faster than 30. This here's a nice example of wickets. This is like the worst one in adults. Oh my gosh, it's so hard. But the big thing about wickets is they're usually in a rhythm, and they're usually in an alpha rhythm, kind of in the temporal head region, and most of the time during drowsiness. And they don't really interrupt the background in the sense that each waveform kind of abuts the next one. They don't really change. They don't evolve in terms of their complexity. They don't become higher in amplitude. They don't spread from the, I guess, maximal here at T7. And like I say, it's an alpha frequency, and then it's also very, very brief. So we probably wouldn't call this interictal. What do I mean by wicket? I think they mean croquet wickets. I think that's what it's supposed to look like. So it's almost like at the peak, a little blunt as opposed to being sharply contoured, which means as you get to the peak, it gets more narrow. So this is almost the other way around. It gets more blunt, almost like a McDonald's arch is the other way to think about it. So then we have mu rhythm here. So this would be, again, an alpha activity, but seen instead of in the temporal head region, the central head region. And usually if you even think about moving your contralateral hand, it extinguishes. So you can ask somebody, move your other side of your hand. So it's C4, you have to move the left hand, and boom, it goes away. Or if it's C3, you have to move the right hand, and it should go away. You should theoretically kind of see it on both sides as well, most ideally, but sometimes we only see it on one side, and then we have to make the call. Is there something else going on here besides just mu rhythm? It's also quite archiform, much like wickets. Maybe even a little less scary in that, you know, I would say like the peaks here anyway of the downgoing potential are not particularly spiky. For instance, they're a little more rounded, and this also could be thought of as a McDonald's arch kind of thing. So again, benign variants tend to be more broad at the peak as opposed to more spiky at the peak, if that kind of makes sense. So here we have an example of asynchronous mu. So first you see it in the left, central head region maximally, and then you see it in the right central head region maximally. We say oh, whoops, my mouse should be over here. There we go. Left central and then right central. And it's asynchronous because it doesn't occur together. So when we say asynchrony, it means not occurring at the same time, versus synchronous means at the same time. And again, this is an alpha rhythm that doesn't evolve. It doesn't really build. I wouldn't even say it really spreads because, the instant it's in C3, and then at the instant, we see it in C4, it extinguishes over here. So spread almost implies that it should continue in this head region while still being in this head region, most ideally. That's usually how I think of spread being in a focal seizure. With the exception maybe of the neonate who's undermyelinated, you can sometimes see independent seizures happening at the same time in that person because there's no spread, because there's no white matter myelination, which is pretty tricky. So again, benign variant. Rhythmic mid-temporal theta of drowsiness is pretty mean. This one's definitely pretty scary in a lot of cases because, you start off with kind of faster rhythms coming in, and all of a sudden it slows down. So you're like, oh man, like, did that change? Well, it's definitely different than it was before. But the good news about this one is it should be ideally during drowsiness. So you can kind of tell state change there. Maybe you're going from wakefulness to sleep, and then you'd expect to see this in the middle. So that can kind of give you context, I guess. They also tend to be a theta, meaning they should be 4 to 7 hertz, and they also tend to be notched. So if you look really closely at this guy, if I had my mouse over, sorry, here we go. There's almost like an up-down kind of notchiness to this rhythm that repeats in a theta frequency. So I'm calling kind of this whole, like the bigger potential and the smaller potential one, and then you stack them on top of each other, and that whole thing is a theta. And so that tends to be RMTD when you see the notched appearance of it, especially in the correct state. Now, that being said, you have some pretty solid posterior dominant rhythm going on here too, right? So that's, this is a tough call here, right? Because you'd think this should be totally gone if you're drowsy or minimally kind of breaking up. You might even see vertex sharp transients of drowsiness. So here we just got to be extra careful. Did this really change over time? Well, I would argue it doesn't build, it really stays a theta frequency. It really stays pretty localized again to the left temporal head region, right? And then it kind of extinguishes before it really assumes any kind of like spike wave. And it's also pretty brief. And let's say the patient has some drowsiness in the next page or two, then you feel a lot better about yourself. It's like, at least they were falling asleep, something like that. But this is a tough call because you're right. The PDR is going on at the same time, which also is a benign variant, rhythmic, but does not evolve. This is an example of 14 and 6. I always find 14 and 6 really, really hard to see, but it tends to be in teenagers and kind of the posterior temporal regions. And it means 14 hertz with 6 hertz positive spikes. So I usually put this one on average reference, which is different than this page. And then you see down going at 6 hertz. usually in the posterior temporal head region. And so, 6 hertz down going, that's positive spikes, 14 and 6. That helps me a lot of times to see this. Also, to be honest, this is the benign variant that on the test, I'm like, what are they trying to cue me in on? Like, it's the hardest one to see, I think, just generally. What second of the page even matters here? That's usually when you pick 14 and 6. To be completely honest, if you see not like wickets are pretty obvious, or like mu or whatever, but if you see like nothing, like 14 and 6 is actually not a bad guess because it's pretty hard to see on most montages in my mind. you know, it's supposed to be this though, 14 and 6, but it's like, oh gosh, is that even all that different than the rest of it? Whatever, okay, but there's 14 hertz in there, and if you remontage it on average reference or Laplacian, you'll see a 6 hertz down going in like T6 or T5, for instance, and that kind of confirms it for you. So anyway, all right, 6 hertz phantom spike. So this is the one where you're supposed to hallucinate spikes, and it's also 6 hertz. So isn't that great? So 6 hertz also tends to be a pretty benign frequency, just generally. That's another thing to file away because 14 and 6 has 6 hertz in it. 6 hertz phantom spike has 6 hertz in it. And I also kind of think of this as like almost like a mitten, but without the thumb bit. Know that in females with occipital predominance, this is almost always a benign variant. In males, sometimes if we see it in the frontal head region, we get a little uppity about it. We might call it. To be honest, I should know the incidence of it even occurring. It's usually an adult onset things. We almost never see this in kids. But just know that female occipital predominance tends to be more benign. Male anterior predominance tends to be more likely to be interictal. But it really should look like Glure criteria, if we're going to call it, theoretically. And if it remains 6 hertz, it's rhythmic but doesn't evolve, right? So again, benign variant because it's a rhythm that does not evolve. So hopefully that's helpful. Again, the mitten, no thumb, phantom spike. I don't know. Anyway, good luck. This is a hard one too. All right, lambda, this one we'll see all the time. So these will be occipital potentials seen during wakefulness, which are kind of like isosceles looking things, like maybe this or this, They're not even that stand out, really. So I almost never call lambda interictal because it doesn't even pass standout. But you'll notice it a lot of times in the posterior head regions. And again, being very isosceles, the up and down is exactly the same. So it doesn't pass asymmetric either. It never has an aftergoing slow wave. And we really should only be calling lambda during wakefulness. And ideally when people are looking at things, that's usually when we see it the most. So if you think about your triangle geometry again, this looks more interictal in terms of the triangle shape, the asymmetric upswing here and downswing, versus this looks very much like lambda and posts being an isosceles triangle, if that kind of makes sense. So anyway, hope that's helpful. So your scalene is your interictal. Excellent. Equilateral. Oh, we see much equilateral. What can I say? All right, so what causes posterior dominant rhythm? Well, it's the resting potential rhythm of the occipital lobe with the eyes closed and relaxed patient. And it's not lost with single eye closure either because both of your eyes hit both occipital lobes, if that makes sense. So your eyeball nerves half cross at midline for each eye and hit both occipital lobes. So if you have even one eye closed, you theoretically should see it. If you have both eyes open, it should extinguish because there's no longer that resting nothing potential getting back to your occipital lobes, if that kind of makes sense. So make sure the patient's got both their eyes closed. Don't cheat, is my point. Great. Also, you should still see posterior dominant rhythm, at least in half the brain, even with somebody with a large PCA stroke, and with either eye closed, because both eyes serve the contralateral occipital lobe, and the contralateral occipital lobe minimally will still have that rhythm. But you can see asymmetric posterior dominant rhythm in somebody with like a PCA stroke or a tumor. So looking for that also can be quite helpful. Looking for, say, a structural or functional lesion of the occipital lobe. And this also gives you a lot of information about, the eyeball all the way back through Meyer's loop and then the occipital lobe too. So this is a really nice, kind of big chunk picture of the long tracts of the brain. This is posterior dominant rhythm in an infant. How old is this infant? Let's see. Well, I would guess, to be honest, I do have a lot of electrodes on you, right? This might even be an adult. To be honest, probably this is an adult EEG, again, showing the posterior dominant rhythm at about, what is this? I would count it at probably 9. Oh, shoot, I keep moving my mouse to the other side. Probably around here. You can see a well-sustained occipital potential, which is about in the alpha frequency. Know that at less than 4 months, we really don't expect to see a PDR in people because you haven't really myelinated up yet, so you won't see that eye closure rhythm yet. Once you get to be 4 months, we expect it to be about 4. Once you get to be 6 months, we expect it to be about 5. 12 months, about 6. Then once you're 5, it should be 8, and it should not slow down below 8 after age 5. So anything slower than 8 after age 5, we're like, oh, this is, definitely abnormal. Also, there's a good chunk of adults, and this is adults, not kids, who don't have posterior dominant rhythm, so we don't always call that abnormal for adults. But for kids, it's always abnormal. We call it moderate encephalopathy in that case because we really do expect it in children. So, and your PDR, once it reaches alpha, it usually gets to about 12 or 13 in your teens, and it kind of falls off as you get to be into your 60s and 70s. So it might go from like 12 back to 8, but it really should stay 8 or faster, if that makes sense. All right, cool. This is a 10-year-old girl again. More posterior dominant. I think we've beaten this like a dead horse. Let's keep going. Phonic driving. So here we go. We're using our lamp here. We see this is probably, how many hertz is this? 8 hertz. And this might be actually a fast harmonic of 8 because I think this is probably about 16 hertz in a second, which if you're shining 8 hertz, you can either see 8 times the light signal gets back to the occipital lobe, or a harmonic, which could be either 16 or 4. You can even see that potentially in people. Harmonics mean that there's like a notched potential in the middle of so it's a biphasic single potential. And so that's why it's a harmonic, is because you multiply times 2 to get it, sort of thing. So normal phonic driving response. This would be normal drowsiness in N2 because we have the posterior dominant rhythm in an earlier page. Here it's breaking up, then it's absent, and we see the appearance of spindles, which should be centrally predominant, which would be kind of around maybe here, this kind of beta activity in the central head region. Not the greatest. Here is better. Yeah, here we go. Much better. Central beta that we see here after a vertex sharp transient. And if we see a vertex sharp transient with a spindle, we also call it a K complex, which generally is induced with knock noises, I think, is my understanding. So if you make a noise in the room, you might see this all of a sudden. It's like, that's why we call it a K complex, because you're knocking it. Causes them to have that. These are thalamically generated. So if you have a thalamic injury, you might have asymmetric spindles. So left thalamus, like bleed or stroke or something, you might only have spindles on the right in the mid-central head region instead of being on the left. So you can look for symmetry of spindles to figure out, okay, is this, this person's thalami intact? The other thing you can see is asynchronous spindles and really long spindles all the way up until probably about like 3. Then they should be synchronous perfectly, so at the same time. But like around like age 2 or 1, your spindles might occur like this, like left side first and the right side, almost like that mu rhythm we looked at earlier. And they're much more archiform, and they're actually a little slower than beta, if you ask me a lot of times. I mean, they're kind of like 11, maybe like 12, and then eventually they do speed up to be beta. So vertex sharp transient. This is why we'll always have a job, because persist will call this an interictal every time, but everybody's got this. So anyway, perfect. Occurs in the central head region during drowsiness and sleep. These don't show up until age 3, though. So if you see these in a neonate, you're like, wait a minute, I don't know about, or sorry, 3 months, not 3 years. 3 months. So if you see this in a 10-day-old, you're like, actually, I'm not so sure about this. And positive central discharges are sometimes associated with intraventricular hemorrhage. So that's something to think about in our really super preemies if we see positive central discharges too. All right, this is a hypersynchrony. This is the bane of our existence too. It's hypnagogic if you're going to bed. Hypnagogic going to bed. Hypnopompic if you're waking up. I don't know, pompic and waking up. Also, I think I put an N in here. Dang, I did it again. Another typo. Okay, I'll fix this. Anyway, point is, it's supposed to be pompic. I don't know why I thought it was pompnic. Maybe I was like struggle bus. Okay, hypnopompic, hypersynchrony. Okay, yeah, here I even have it correct. I don't know how I did that anyway. So, all right, so this is a patient who, they're asleep here because you see central beta. Then all of a sudden they wake up. You see this kind of theta higher amplitude frequency, and then their PDR pops back in after they've woken up. This is a nice example of REM sleep where, let's see, you should see sawtooth waves at the mid-central head region. You'll also see lateral rectus spikes. I don't think we have them here, but lateral rectus spikes will be myogenic potentials, and myogenic potentials tend to be much thinner than cerebral potentials, so less than 20 milliseconds. So for instance, sorry, I'll go to the next page. This is a myogenic potential. Sorry, arrow. Got it. Okay. Oh. Myogenic potentials, because they're just too narrow. There's just no white space in between them at all. So that's going to be a muscle. And if you see just one of those, and not a whole bunch of them, you're like, lateral rectus spike, especially if it's in like F7 or F8. And they're going to put that on your test and be like, is this interictal? You're like, no, this is REM sleep. Awesome. Because it's myogenic. But anything that at least has enough white space, between it to, not be just completely black like this, that could be cerebral. And then buildup phenomenon. So this occurs during hyperventilation because of cerebral autoregulation. When you breathe really fast, it causes your arteries inside your head to clamp down, and that causes slowing. And then if you have somebody with moya, who we shouldn't hyperventilate, but if you did by accident, they have something called rebuild-up phenomenon, which means they build up, and then after you're done hyperventilating, they build up a second time. And if you see rebuild up on your test, or if they mention rebuild up, you're like, that's moya. That's the only thing that does that. That's what you're supposed to do. And also don't hyperventilate that person anymore because they might have a stroke. That'd be really bad. Anyway, good. That's also why we don't hyperventilate people with like history of stroke or who have like active vasculitis or something that kind of pushes them over the edge for stroke to begin with, because, and that's even for our adults with hypertension, right? We're like, I don't hyperventilate them, like they might have atherosclerotic disease, right? What's the chance they have absence as an adult? Like none. Do they have absence as a kid? That's the question you should ask. If like, no, they didn't have absence as a kid, well, then they don't have absence now. You don't develop absence at 60. That never happens. So anyway, why hyperventilate somebody with hypertension? I completely understand why you wouldn't. It's one of those things. Anyway, cool. So build up later with hyperventilation. Again, this is rebuild up phenomenon. So, you had the build up, you stopped hyperventilating, and it continued building up even well after. You're like, oh, I'm kind of nervous about this person. Like, we should probably like check them out with conventional angio or something. And also not do this again. Super. Yeah. Mm-hmm. Yeah, good question. You certainly could. So if you see buildup like well after you're done hyperventilating, that's actually a fair thing to call and be like, hey, I wonder if I saw rebuild up on this case, maybe. The patient should probably have history of strokes, though, almost assured. Like, you ask them, like, have you been paralyzed in half your body before, like several times? They're like, oh yeah, like every other week. You're like, oh shoot, maybe this is moya. Versus, if they've never had that before, we'll look at it. We'll decide if we need to keep working about that sort of thing. But just know that this feature, I don't know if this shows up on your boards. It definitely shows up on ours. So if you see the term rebuild up, that's what they're fishing for. It's just a buzzword, and it means build up after you're done hyperventilating. So this also, like I say, it's a theta pattern, kind of, or well, I guess it's theta 2 alpha. How fast is this? 1, 2, 3, 4, 5, 6. That's theta. Theta pattern's higher in amplitude. That really doesn't change very much, right? Like it's a rhythm, but it doesn't evolve. So that's how you know it's not a seizure, because it's not changing over time. It doesn't become more complex. There's no, 6 or 7 hertz that becomes a spike wave. It's instead just like at most maybe sharp activity, but in a rhythm. So, oh yeah, great question. So no, probably. If you did have a big stroke though, you would see flat in a chunk. Because you'd have clamping down. Oh, good question. Well, maybe. Well, they should clinically also look like stroke too. I mean, really, if they had rebuild up and then had a stroke and you saw flat in a chunk of their EEG, they also should have some clinical sign with that probably, because that's a big chunk of brain to impact, meaning our spatial resolution on EEG is not that good. So to detect a whole hemisphere out means that you've really stroked out a huge piece of brain, or to detect like a whole channel go to nothing means you've really stroked out basically a whole lobe. So it'd have to be like an MCA or an ACA or something like that. And that means then they should have paresis or aphasia or some, meaning difficulty speaking, or face droop or something else to cue you in. That's a fair thought. Yeah, if you see build up, well after you're done with hyperventilation, it would be okay to call the referring physician and just let them know, hey, I wonder if I saw this rebuild up. But it's not, moya is not that common, and the patient really, again, probably should have like strokes in their history, probably, if that's the case. Not generally is my understanding, not generally. They would if they became flat. So if they started stroking, they would definitely have clinical symptoms, hyperacute, like immediately. And it wouldn't be positive symptoms either, it'd be negative symptoms, right? Because it's a stroke. So you'd have anesthesia, face droop, not moving half of my body, not speaking, not seeing things. Does that kind of make sense? So the opposite of a seizure, it's like literally the exact opposite of auras. You're like, oh gosh, this is a stroke. Like, call stroke 1. Like, that's fair to do. I don't think this will happen to you, probably. I've actually never seen this yet. Hopefully I never do, because moya is the worst. I don't, we put them on aspirin to revascularize them, but man, they have a lot of strokes. It's really rough. Also, people who are at risk for moya would be like people with trisomy 21, they get moya. People with like really bad HIE, but then you can't hyperventilate those people because they don't follow commands. So you probably would miss the people who would have this most of the time for hyperventilating. So, oh, that's fair. Yeah, that's a good thought. Yeah, because they may have like some sort of crisis and like thinning of their arteries in their head already for that reason. Then you hyperventilate them, and then that can cause. So, yeah, to be truthful, I don't know that you have to hyperventilate sickle cell most of the time. Also, because childhood absence comes on between 4 to 8, and you almost always see discharges with that anyway. Versus if they're like 15 and they have sickle cell, I actually probably would call and ask if we need to hyperventilate them in that case, because the reading physician or the ordering physician can help you decide on that. And they'd say, maybe the risk of hyperventilation outweighs the benefits. I'm really just looking for I think they might have focal onset seizures. And if that's the case, you don't have to hyperventilate at all. If we're looking for focal epilepsy, what's the point in hyperventilating? Because that induces absences, which are generalized. So great question. So yeah, this is tricky. I will say, I do tend to activate most people if it's not a clear contraindication, just because why not? But if there is a clear contraindication, don't feel bad in pushing back and be like, hey, I'm just kind of nervous about sickle cell or history of stroke or history of brain tumor or history of hypertension or something like that. Generally, we're going to be pretty, at least I think we're going to be pretty reasonable, because it's like, well, if we're looking specifically for absence, we should probably do it. If we're not, why do it, right? It's risky for nothing then. Does that kind of make sense? Strong work, team. What a tricky thing. But anyway, just know that this is the real thing. And this is still technically not a seizure, but it just shows you that their brain vasculature actually is a little insufficient for the hyperventilation maneuver. That's what this shows you. So it's not a seizure, and they're not likely to have a seizure right now. They're actually more likely to have a stroke right now, which is the opposite of a seizure. So excellent. All right. This is a continuous neonatal EEG. There's no posterior dominant rhythm here. They should probably be noted to have their eyes open here. It's kind of a low voltage irregular pattern with lots of intermixed frequencies here. And there's no like higher amplitude and lower amplitude that we see in traumatic alternon. Versus here, this would be quiet sleep. So you see bursts of moderate amplitude cerebral activity, which are generally in the delta theta range. And they're kind of brief, of like maybe 1 to 2 seconds, but nice and synchronous. And there's interburst intervals, which tend to be less than 6 seconds-ish. If they're longer than that, I tend to call prolonged interburst intervals. And it really shouldn't be flat. If you crank the sensitivity up, meaning number going down, I think that's right. I always get those two mixed up. Anyway, if you make it more sensitive and make the waveforms bigger, you should see some activity in the interburst interval too. So it's not burst suppression, it's quiet sleep. This is more quiet sleep, just to give people an idea of how there's difference in terms of this block here is more moderate in amplitude, right? And this block here is lower in amplitude, but still nice and continuous. There's always cerebral activity, and it's nice and symmetric too. Synchronous, I should say. Sorry. So the left side and the right side activate at the same time. And there's symmetry too. What the heck? Symmetry is great. You guys have the most symmetric EEGs I've ever seen. Perfect electrode spacing. It's excellent. Awesome. Note there's variability in the neonatal EEG in terms of how continuous it ought to be, whether or not you see traumatic alternon or not, or if you see traumatic discontinu, say in the more premature infants. Those ones tend to have prolonged interburst intervals, less bursts of cerebral activity. Anyway, we'll tell you if it's premature or dismaturity or whatever, if based off of our age. Generally, that only means that we don't know how old the baby is. If we say dismaturity, it doesn't mean that they're likely to have seizures or not. It just means we suspect that their age is not the same as what is stated, because their EEG looks younger, or potentially their EEG looks older than they stated, and so maybe their term, so you can kind of grade your age based off your EEG too, in some sense. Cool. All right. Let's see. Also, you can see some normal graphic elements in babies. Know that specifically the rhythmic temporal theta can kind of fake you out a little bit, and that is, again, a rhythmic pattern, but doesn't change over time. Delta brushes are almost never called interictal because they're a delta with fast activity on top. And so it's like two rhythms intermixed that are not spike wave, and so that's not likely to be interictal because that's minimally polymorphic. Then you see encoche frontal as well, which tend to be kind of repetitive. Well, I'll show you these. What the heck? Sorry. Delta brushes, rhythmic temporal theta. So delta brush would be, again, kind of a delta broad wave with a fast activity on top. And these are seen in more premature neonates. As you become term, they extinguish. Rhythmic temporal theta is seen even a little earlier. in kind of like earlier preemies even than the delta brushes. Yes. Yeah. Mm-hmm. Yeah. Yeah, certainly could. And that's really tricky. I tend not to call brief rhythmic discharges, which is repetitive sharps in an infant, if they truly have morphology of delta brush, because delta brush really is a normal element. Ideally, if you did see it multiple in a row, it really shouldn't change very much because it should be a delta with beta on top, but then the beta doesn't evolve or slow down, speed up, become more complex. Neither does the delta. There's also extreme delta brush, though, which you can see in NMDA receptor encephalitis. So that'll be basically delta brush, but the whole page. We'll look at that in a minute, which is basically the whole page is delta with superimposed beta. And those people have autoimmune encephalitis. And if they're a girl, maybe teratoma. We'll see. But yeah, great question. So delta brushes, they certainly could occur in a periodic pattern. They're usually not rhythmic unless it's extreme delta brush, but they could be periodic. So maybe occurring every second. It's okay to call us about that. We can look and be like, we just think it's delta brushes occurring at 1 hertz per second with a nice, flat in between them. They don't change. So again, no evolution, but could be, minimally a rhythmic normal graphic element in this child. And we're happy to review that too, because neonatal EEG is a challenge. It definitely is in some cases. Oh my gosh, especially with those smiley face leads. Strong work. Anyway, trying to protect scalps, I know. It's one of those things. Mm-hmm. So here we have encoche frontale, which is French. Anyway, it's this upgoing potential in the frontal head region that almost looks kind of swoopy on the way up, is the way I think about it. So it's kind of like not all one slope. Unlike the interictal we looked at earlier, that was all one slope up and down. So if it's kind of a swoopy at the start, very unlikely to be an interictal there. And especially if it's on both sides of the head at the same time. And these definitely do occur in rhythms sometimes. You might see like 3 or 4 of these in a row. But again, they should be about the same amplitude. They really shouldn't change in their frequency, and they definitely shouldn't become more complex. They should stay very patterned, like one hand on top of the other, if that kind of makes sense to be encoche frontale, which again is a normal element, in term infants. So here's an arousal in a baby. So you kind of you're going from the more trochlea alternatum appearance to now all one amplitude, kind of mixed, low voltage irregular patterns, what I'm trying to say. So intermixed, fast and slow here. So excellent. Here's the bad. So again, Glore criteria here. I think actually I'm sort of reviewing, aren't I? Triangle geometry, excellent. I did that. Okay. So here's bad. This is pretty flat. So also let's say the sensitivity here, maybe it's 3 or 2 or something. You're like, oh dang, there's just not very much cerebral activity here. This can be definitely a pretty bad situation for people. We also can see burst suppression post HIE, and if you're having myoclonic jerks with this, we call that Lance Adams syndrome, and the chance of recovery after that's actually pretty low. I want to say bad outcome is, I should remember the exact percentage, but I want to say it's like 98% chance of a bad outcome with this alone. And then sometimes we throw the somatosensory evoked potential on top, or get the MRI of the brain to see diffuse injury to like double confirm that we're actually correct about that. Also, if they're like on no sedation, they look like this, that's a lot scarier than if they're on pentobarbital. If they're on pentobarbital and they look like this, you're like, oh, we're doing this to them almost. But then these bursts are very mean, generalized. I wish I could actually bring the sensitivity down on these, right? Like maybe this is a sensitivity of 7. They're huge. They're bonking into each other. So if we brought the sensitivity down, they'd be very asymmetric, spike and slow wave discharges associated with twitching for the patient. So there we go. Down. Here we go. Theta coma post HIE is also quite bad. This would be basically invariant theta pattern, which is not reactive to cares. So anytime you don't have reactivity to cares, that's always bad too, because you expect somebody when you stimulate them to go from a more sleep or kind of a slower with sleep elements to transition to that nice hypnopompic hypersynchrony, and then maybe see their PDR pop out. You don't see any of that with theta coma. So just like, oh, darn, this person's not doing so well. This also portends a bad prognosis. Alpha coma is similar. So if you're only alpha but nothing else, that's also bad. So you should have a polymorphic EEG. And polymorphic again means intermixed fast and slow frequencies, not all one frequency. So anytime you see all one frequency, it's pretty bad. This here's a nice example of focal slowing, which is left-sided. I'd have to, well, anyway, you can't see the channels on this. This is really unfortunate, but obviously this person had a big stroke, and this would be maybe the look of somebody after rebuild up. Oops, my mouse. There it is. This would be a look at somebody after rebuild up if they were having a stroke. Like they really should flatten out if you're, anyway, just be aware of that. Awesome. Here is more focal slowing on the right side. So it's kind of more delta range frequencies with the fast activity on top, especially in the kind of F8, T8 kind of channels. I know those that convention is not exactly what we use, but anyway, just be aware that's focal slowing of the right temporal head region, somebody with a brain tumor. Ouch. This is childhood absence epilepsy. So you can see seizure here that's 3 hertz and about, stacking on top of each other yet again. Let's see. Okay. Maybe we'll run through just a couple more seizures and then we'll stop and for questions. How's that? Because I have way too many slides as usual. Childhood absence epilepsy should be like stackable artwork. That's different than an atypical absence. These people also will have abrupt behavior arrest with it. So they'll just stop whatever they're doing and eyelid flutter. Versus the atypical absence, people will have more irregular, meaning not every spike and wave stacks on top of each other as prettily, as pretty. I think that's right, as this figure does. And they may or may not stop in the middle, and they tend to be slower, like about 2 hertz, like 1.5 hertz, something like that. They can also be longer. So childhood absence epilepsy tends to be about 10 seconds per seizure. Atypical absence can be a whole minute. So it can be really, really long sometimes. And then depending on the look of that, you can then predict, okay, my patient's either going to have normal development in this case, probably at the onset of their epilepsy around 4 to 8 years old, 80% chance of outgrowing it, versus if you have atypical absences, that's highly suggestive of a bad genetic epilepsy and they're unlikely to outgrow it. So that's kind of nice to know. So, okay, lots of examples of the same. Okay, this would be atypical absence, but in juvenile myoclonic epilepsy, which is actually a little faster than atypical absence in a symptomatogenic epilepsy. So faster absence, and these tend to be much briefer in juvenile myoclonic epilepsy that I've seen. They also tend to have polyspikes on their EEG. So if you see polyspikes in a teen who's had a first-time convulsion and then they have morning myoclonus, you're like, juvenile myoclonic epilepsy. Tends to be a generalized epilepsy syndrome too. Though, as we talked about, these people actually can be medically intractable, and we do spell capture them on purpose because this is genetic epilepsy. But if you have acquired epilepsy on top, you still might get a surgery potentially. Say if you had like a brain injury on top of this or something, your seizures may actually be focal instead of generalized. So we don't immediately box people out if we see a generalized discharge like this from an epilepsy surgery until we've caught their seizure. So thanks again for all your help with that. That's super. This will be photoparoxysmal response in juvenile myoclonic epilepsy. So again, at 15 hertz, we see spike wave discharges emerge. You take the light away, and the spike waves stop and it doesn't persist beyond, and they don't convulse in this case. So you can also give them a code word during this and see, were they aware during this or not? You can then repeat this with the lenses and make sure that it's actually replicable. I guess there are probably some circumstances where people could have discharges during photic stim just randomly. So it's important to repeat in all cases to see this, because if you don't repeat, you don't know it's photic induced. So that's a tricky thing. But as soon as you see it, you don't have to leave it up there for like 10 whole seconds. You can pull the light away and you already have your answer. So just see it for a second or two and then be done. We that's good enough for us. This is a generalized tonic-clonic seizure, which at onset appears to be a rhythmic kind of spike wave discharge that then is overcome by the tonic phase, as their muscles all stiffen, including their frontalis and temporalis muscles. Their brain activity actually is not none here, but just completely obscured by muscle activity. And then they go into clonic phase. And the clonic phase, you actually see evolution of the seizure because it slows down, right? So unlike the benign variants we looked at, there's rhythmic pattern here that then slows and then it stops. So that's kind of the anatomy of a generalized tonic-clonic seizure. This is the tonic seizure. So generalized paroxysmal fast activity in somebody who has maybe a slow spike and wave background. That would be a tonic seizure there. Another tonic seizure. Excellent. This is a left lateralized temporal seizure that starts off probably about 3 hertz, builds in amplitude, becomes a little bit more complex because here it's kind of sharp. Over here, it's probably a little closer to spike. I'd say it's a little more narrow here than there, if that kind of makes sense. The morphology has changed. And then as you get really, really late in the event, you start to see that there's a spike component and an aftergoing slow wave, which really wasn't present over here. Does it spread much? I don't really see a ton of spread here. So this person might even be aware. If you give them a code word, they might actually remember this. Or if they don't, what that means is they've minimally knocked out both hippocampi, but the onset of this at least looked left, we think. That's a bit tricky. What if you started deep right, propagated left, boom, you see it. So we could false lateralize sometimes doing that too, which is also why the code word is super important, because if they do remember it, we're like, yes, it started left, it stayed left, right? If they don't remember the code word, either started right and then wound up on the left and we saw it, or it spread from the left to the right, one of those two, right? So if they don't remember the code word, we're a little more nervous about just doing surgery on this person. So the code word is actually very helpful in this case. Hypsarrhythmia that makes no sense. That's easy. Also, there's no anterior to posterior gradient. Also, your sensitivity on this should be like 30. So they'll crank the sensitivity up real big on your test. You're like, what is the sensitivity? Why is the sensitivity 30? If your sensitivity is 30 on your test, it's hypsarrhythmia. Don't even worry. Nothing else does this, okay? So it's very simple. There's some things that just really help you to, nail your test. Piece of cake. So also this infant would be like maybe like 4 to 6 months old. They might have trisomy 21. They might have tuberous sclerosis, a whole bunch of skin marks to go with this. And then their seizure, actually, the only way to seize out of this is order. You know what I mean? So the evolution of complete, oh, whoops, here it is. Sorry, wow, I went right by it. The evolution of complete nonsense is delta and decrement. That's what you're looking for. Okay, how else do you evolve out of, disaster? And then also stiffen and have clusters of these, usually out of sleep is the time that they'll have their infantile spasms. Awesome. This could be generalized non-convulsive status. Go ahead and call us about this. This is scary looking. We would we would say hi and decide if we needed to add a van or not. But it's not quite 2.5 hertz. It's probably close to 2 hertz. So we might even call this like a, if there was more of a flat in between, this could be a periodic pattern. Like maybe here you could argue as they're flat there. But actually, I'd probably treat this person. This is really scary looking. You treat them with Ativan, the discharges get better. Also, the patient should wake up because Ativan makes every pattern look better. It should make triphasics look better. It should make generalized periodic discharges look better and lateralized periodic discharges. But the patient should look better if they were in non-convulsive status, if that makes sense. So they should wake up and act more normal. This we would all call because it's about 3 hertz and it's clearly like there's waves with admixed spikes and it's a rhythmic pattern, so a non-convulsive seizure. So maybe that's probably a decent place to stop for now because it's been about an hour. Unless do we need to keep going? I have a little more, I figure. It's maybe just like, let's just fly through a couple more real quick. Sorry. Yeah, in many cases. So this would be padding artifact. You guys see this 1,000 times. The parent is padding. The field makes no sense on padding because it's everywhere. And it comes out of like, nothing. All of a sudden it's there. And if your parent is really savvy, they can slow their padding down as they're padding, but hopefully they don't do that. Oh my gosh. That's the worst. Anyway. Positive sharp waves like this. So when I say positive, it means the deflection is instead of toward each other, they're away from each other. And this could either be artifact or if it were cerebral, it could be intraventricular hemorrhage. But I think this is more artifact because it's kind of ratty looking, meaning the potential kind of goes up, down, up, down, up, down like that. And it's a positive deflection. So that tells me they're probably wiggling their wires around. That's what wire artifact looks like a lot of times. Very fair. Good point. I like that. Maybe that guy needs replaced if it has 60 hertz in it. Good call. See, that's the one thing I do know about replacing electrodes. There you go. Very good point. Because you'd expect something that big to have a field to adjacent electrodes because it's a very different voltage, and it doesn't. So very good point. So this is likely artifact because, if it had a credible field, you'd expect to see it also not in. This is in the T7 is what I believe this should be in because it's only in channels involving T7. So that's your bad electrode in this case. And nothing adjacent has it, like all of the FP1, then you'd expect it to see it in other FP1 channels, but you don't. So very good. Strong work, man. This is why we're a good team. That's right. Crushing it like a boss. All right. Yeah, positive sharps can be interictal. They're unusual because most of the time all your discharges will be negative relative to your scalp. That's just how your electrons are ordered. Yeah, okay. This is the extreme delta brush. So again, it's basically a delta brush that's seen throughout the whole EEG. Also, this would be a teenager. So you're like, wait a minute, they're not premature. They're teenage. Why is this? And then you realize, okay, they have limbic encephalitis maybe, and perhaps they have a teratoma, which for some reason grows teeth. Isn't that awful? Anyway, teratomas grow anything they want. So anyway, they can even grow a whole face. Isn't that awful? Anyway, all right. So this is triphasic waves. It's triphasic because there's 3 phases. The biggest phase of a triphasic wave tends to be the positive deflection, and they tend to have anterior to posterior lag, meaning if you hallucinate an up and down line, whoops, where's my arrow again? It's coming, I think. Did I find it? No. Oh, here it is. Okay, great. If you hallucinate an up and down line, you can think the peak of this wave is a little earlier than the peak of that wave is a little earlier than the peak of that wave. So there's almost like a slanty to it. That's another way to tell triphasics from generalized periodic discharges. And generalized periodic discharges tend to have the maximal deflection be negative. So they'll be upgoing on ear reference versus this tends to be positive downgoing on ear reference. So, or in this case, we're technically in AP bipolar, but still, because it's a generalized activity, it's all downgoing in the positive deflection. So, or in the second deflection, which tends to be the biggest one. So, super. More triphasic waves. Awesome. This is lateralized periodic discharges, which is HSV meningoencephalitis till proven otherwise. This is periodic discharges that is faster, like about every 1 to 2 hertz. That could be Creutzfeldt-Jakob disease, which is prion disease. Also, if you're every 5th hertz, that's one that shows up on our test as subacute sclerosing panencephalitis, which is after measles. So you can kind of guess what their pathology is based off of how fast their periodic discharge is. This is Lennox-Gastaut, which is slow spike and wave, which looks really bad. We're happy to look at these people. Oh my gosh. But it also doesn't really evolve neatly. Like you can kind of see it kind of slows down, speed up, slow down, speed up, kind of in a sputtery way. And then there's also oftentimes, again, a period, which would be kind of a flat in between discharges. Of course, this page looks pretty nasty, so you might want to look at the rest of it. This would be generalized periodic discharges. Awesome. There's definitely flats in between. There we go. There's definitely flats in between these upgoing discharges. So this would be a on both sides of the brain generalized periodic discharge. So this is tongue artifacts. You can tell them, what do you tell them with glossal connect? You just tell them, stop moving your tongue, move your tongue, and it makes it better. Perfect. See? Great job. Thanks for doing that for me. This is chewing artifact. You can't tell what they're eating, but someday maybe I'll be that good. This is pulse artifact. Pulse artifact comes after the QRS. So if you take this and you pull it upward, the deflection of the wave should be the same deflection immediately after each QRS. That's how you know it's pulse artifact. If it's on top of the EKG, it's EKG artifact. If they're a very small neonate, they can trick you and call it cardioballistic artifact, which just means that the heart moved their whole body. It's basically the same as pulse artifact, but it's a different answer on the test. You're like, dang, man, they got me. Anyway, it's all artifact because it will always follow your EKG. And if there's more bumps than EKG QRSs, then you're like, ooh, wait a minute. Call us. That's fair. Nothing wrong with that. So go ahead and count your bumps in your QRSs. Hopefully this doesn't last for too long because I'm sure this is a nightmare to watch in real time. Anyway, super. Electrode pop artifact, same as what Haley brought up earlier. It tends to be only in one electrode. It's really huge and it doesn't have a credible field. So here the bad electrode would be P7 if I'm reading this correctly. I think this is really small. Oh well. So artifact is slow. So it's slower than 1 hertz. You can increase your low frequency filter to filter this guy out if you got to. Tell them stop sweating so much. Breach artifact means we took their skull off, and so it's higher in amplitude and faster where the breach is. So it does pay to look at your operative notes from your neurosurgeons who kind of mess up the EEG forever every time they take somebody's skull off, curses. That way you know which side the breach should be on. I do this all the time because the problem is you're going to see spiky stuff in a breach. And if it's only in the breach and not outside the breach, that may or may not be interictal. So we're careful about calling interictals within a breach because you're just going to see faster frequencies after the skull has been taken off and higher amplitudes as well. Great, more breach rhythm. This again would be on the right side because you see, well, yeah, I think it's right side breach. This is supposed to be C4, I believe. Correct, on the correct side, right. And then you look and you're like, oh my gosh, yeah, the skull is like really thin on the right side. It makes sense as to why the waveforms are so big on the right compared to the left. Excellent. Right. And then, okay. EKG artifact means the EKG shows up in your channel with the QRS at the same time as the abnormality on the EEG, sorry. Focal polymorphic delta would mean a focal slowing in that head region. And then we also have a left-sided breach artifact, it says, which would be kind of faster amplitude. No, it's on the right. Sorry, this. It's Left-sided breach artifact. Okay, I can buy that because these amplitudes and these channels here. Oops. If I use my brain, there we go. Then I get my mouse again. Sorry. Oh, there we go. These electrodes here are higher in amplitude than the contralateral side, despite perfect electrode placement. Strong work. And there's maybe a little bit spikier frequencies in these three channels than in these three channels. And that's how you know there's a left-sided breach compared to the right. So there's a whole lot going on in this one EEG. Awesome. All right, I think we made it through. Any questions? Oh, yeah, thank you, guys. Appreciate you. But yeah, any questions about this? So basically, if it's rhythmic but doesn't evolve, you can probably name the benign variant. If you can, you're like, it's not a seizure. Or if it evolves but isn't rhythmic, that's likely lambda or posts against some sort of benign variant. If it's rhythmic and evolves, call us. We're happy to say hi. Perfect. Excellent. All right. Hope that's helpful. So, yes, Julia. I really don't very often. I think it's more of an adult thing, but I don't know why that is. I should know. It probably has to do with like cerebral maturation and stuff like that. Because if you think about it, most of our kids, like their frontal lobes aren't even completely developed yet. So an 18-year-old, even though they have posterior dominant rhythm as alpha, like their cognitive faculties are not the same as a 25-year-old, which is why we don't let them drink yet. Obviously, come on, let's not be ridiculous. So it probably has to do with the connectivity of the adult brain compared to the child brain, but that's a good question. I really don't see them terribly often, but if you do see it, it's an invariant rhythm that really isn't polymorphic and doesn't change with care, and that's honestly just about as bad as like a flat or invariant delta. That would also be bad. We usually call delta with no other rhythms a severe encephalopathy in that case. So, and we'd probably call alpha coma and theta coma the same. I will admit, in fellowship, I might have seen it like one time, maybe. Post anoxic brain injury as well in an adult, I think, if I remember right. I'm trying to remember exactly when that happened. Oh, you did? Wow. It was rough. Oh, were they over at like university or something, like super sick person? Or okay. Seems fair. Adult hospitals probably more often than the peds version. But you should stimulate them and then not see change to their background. That's how you know it's one of those. And then you grade the coma based off of, well, how fast is the brain going at the time. So anyway, cool. Yes.
Like the seizures,
Mhm.
like positive
Yeah.
symptoms they should have.
Yeah.
So why do you think with like absence seizures, it's aggressive behavior? I know
Yeah.
there's eye fluttering, but sometimes there's not.
Right. That is really, really tricky. So you definitely have loss of your memory there with abscences because they're generalized at onset. So you knock out both Page circuits in that case, and they really don't have an aura to go with it. So generalized seizures, they still have positive symptoms because they have motor phenomena. So eyelid flutter would be considered a motor phenomenon. You're not really supposed to flutter your eyes like that, I guess, with behavior arrests, but you are. So that would be a positive symptom, I suppose. But really the positive symptom of a focal retained aware seizure is the aura, right? So all auras will be positive symptoms. If you have a generalized onset seizure, if it's a motor seizure, the only positive symptom you're really going to have is movement, I guess. Otherwise, you really shouldn't feel or hear or, sense anything really. So good point. It does break down a little bit, but I would also argue, there's certainly no clear negative symptom with it either. Like they don't have paresis because the instant they come out of it, they're like fine again. They don't complain of anesthesia. In fact, they complain of nothing because it's just lost time pretty much, so they don't have any like perceivable deficit. They have instead kind of a anosognosia, which is a big word that just means I don't know that I have a problem to begin with. And so anosognosia, that's also kind of a gray zone. That's a hard thing. Sorry. So if they don't know that they have any problem, then you don't know then if that's clearly seizure or stroke. But if they know they have a problem and it's something they should have but they don't have it, that's a negative symptom. And if they do know they have a problem and they shouldn't have it but they do have it, that's a positive symptom. So the exception to the rule is lost awareness immediately because then they can't even describe what they're feeling to call it positive or negative. That's really tricky. Does that kind of make sense? Sort of. Clear as mud. Generalized seizures, the positive symptom will be motor activity, even very subtle, like eyelid fluttering, or maybe tilting their head back, or maybe dropping their head forward, I suppose, if it's like atonic seizure or something like that, So, yeah, for sure. Yeah. Yeah. Yeah.
Would that be considered absence because of how long it's lasted?
That's a good question. Well,
And that person is responsive during it.
yeah, yeah.
But it is continuous 3 hertz spike away.
Right. Yeah. That's a
And they
great
can
question.
answer questions like
Right.
what's your name?
Right. Yeah.
Who knows? That's my finger.
Right.
They got halfway across the dot.
Wow, there you go. So they have kind of motor impersistence almost. Wow, I believe you. That is hard. I tend to call it atypical if it doesn't meet the 3 hertz criteria and doesn't look stackable like the childhood absence epilepsy there. And I think that's in keeping with pretty much all the epileptologists here. Yeah. And it's unusual to be in spike wave stupor. The most common reason why people wind up there are absence status. Those are synonyms. The most common reason is we put people on the wrong drug, like we slam them on oxcarbazepine when they're supposed to be on. Also fair. Stop taking your medicine's a great reason to be in status. Oh my gosh. So yeah, I wouldn't call it atypical in the sense that the frequency is slow or fast. I would call it unusual, I think, but I don't know if it's universally called atypical. I can get back to you on that. It's not, I don't think it's quite in the same bucket as atypical absence because that suggests either a juvenile myoclonic epilepsy if it's fast or a symptomatogenic epilepsy like Lennox-Gastaut or some. Yeah, right. Yeah, yeah. I would just call that absence status in that case. It's not atypical absence in that sense, but just the fact that it's absence status or spike wave stupor are the terms that we use. Yeah, good question. And then yeah, as it goes on, for some reason, I guess they look better than their EEG sometimes. And I don't know why that is either. That's a great question. I guess the thought would be, I mean, we are detecting, 10, Ebersol says we're detecting 10 to the 8th neurons with our, 2 buttons, right? So, within the brain, there's, a billion neurons. It's more than 10 to the 8th for sure, And so maybe we detect the spike wave at our button, but there's just enough cortex not activated at any given time that you see the spike wave, but they're more functional than you think. That's a hard thing. Good question. I don't know why that is yet. Maybe one day if we have better spatial temporal resolution of our EEG, or if you have intracranial electrodes, you might see that a broad pattern is more focal than we think. But the problem is if it's on both sides, we call it generalized right now because we don't have a good way of knowing like, it's clearly left or it's clearly right. So we have to call it generalized if it's bilateral. But probably, and this is another interesting thing that we'll have to see about the Meg once it is finally up and running. But when I was interviewing Dr. Kwan, and I've also read up on this a little bit, there are some people with generalized discharges analyzed by Meg who actually have focal onset of their discharge. So if we analyze the magnetic field around their brain and solve the reverse problem using the Meg, which I don't understand at all, but she does. Ask her about that. Anyway, if you solve the reverse problem, sometimes a generalized discharge is for some reason a horizontal dipole in the left temporal lobe. And you're like, what? That's crazy. But as it propagates through the brain and then hits the scalp, it's generalized. It's on both sides. So we're probably going to discover some of our intractable generalized people once we meg them all. Maybe some of them are focal. And then we can do surgery on them, which would be great because intractable generalized people can't get very good surgeries other than VNS or corpus callosotomy right now. That's pretty tricky. Yeah. Good question, though. That's tough. Spatiotemporal resolution is what I would say is the reason. But, could you predict based off of the EEG appearance how good the patient looks? Oh, no. Yeah. I mean, that's true even of people some people have alpha in their PDR, but they're nonverbal, right? And other people have slow alpha, but for some reason they're developmentally appropriate. And the reason why that is because, again, we're detecting 10 to the 8th neurons. The EEG really doesn't tell you very much about your intelligence. It's really just a measure of what's the electricity doing on the large kind of poorly resolved or as best resolved as we can possibly do by fitting as many electrodes on the head as we can scale, if that kind of makes sense. So anyway, it definitely doesn't tell us about dreams. There is a fun X-Files episode, though, about dreams and EEG, which is laughable. It's very funny. You should look it up sometime. I don't remember the title, but anyway, it's great. Oh, actually, yeah, one more thing. And then I think, there's the book in here. Anyway, this is most of the literature, not including the EEG text. I don't know why I didn't do that. So anyway, no, it does include, no, it doesn't. Okay. Well, anyway, look up the EEG text. I can send it around if that's helpful. If you need a guide, that can definitely be helpful. Pictures speak 1,000 words sometimes. So cool. Anything else? You guys are awesome. Thank you for bearing with me through that. All right, super. And thanks again for the opportunity to talk. Super. Always a pleasure. And that's what I can do to help. So feel free to take those and spread them wherever you like. And yeah,